Sir, we are live on Facebook as well. Just 30 seconds, then you'll be right to go.
చెప్పండి. Is it acceptable? To present the thesis, is it acceptable there? That's what I'm asking. అది ఎవరన్నారు?
Sir, you're on, sir. You can go on.
Okay. A very good evening to all of you. On behalf of Indian Psychiatric Society, Telangana State Branch, Indian Association of Private Psychiatrists, Telangana State, Indian Medical Association, Telangana State, I welcome you all to this webinar on psychological problems in children. Speaker being Dr. Hrishikesh. During this pandemic, apart from us being distressed, our children who were locked in for more than 6 months are much more distressed because of the pandemic. They didn't go for vacations. Neither when their school started, they didn't go to school. Everything is online. Previously, we used to tell our kids that don't watch TV, your screen time is limited. You don't watch screen, phone or TV for more than 1 hour, half hour in a day. But now we are forcing our children to go on online classes and sit in front of screen for 4 hours, 6 hours continuously. So all this is causing distress. So our expert panelists will talk about these issues too. I won't take much time. I would like to hand over the proceedings to our president, Dr. Jagannath sir. Dr. Jagannath sir.
Yes. Okay, good evening viewers. On the behalf of the IPS Telangana State Branch, I welcome all to this awareness program. I especially welcome all the members of Indian Medical Association. Yesterday we had a presentation by Dr. Ramana Cherukuri on alcoholism. Today we have an excellent topic, that is psychological problems in children, which will be delivered by Dr. Hrishikesh, who is a psychiatrist as well as a pediatrician. Today's session is chaired by Dr. Kesha Rao. He is a senior consultant psychiatrist at Chetna Hospital. He has done his MD Psychiatry from Usmania Medical College and MRCP from King's College, London. He has been working as a locus consultant in child and adolescent psychiatry in UK for the last 12 years. He is the past president of IPS Telangana State Branch. Before handing over the mic to the chairperson, I request the IAPP Telangana State Branch President, Dr. George Reddy, to say a few words. Over to Dr. George Reddy.
Yes. Respected President Dr. Jagannath sir, and respected members of IMA Telangana State Branch and members of IPS TSB and IAPP TSB. Warm welcome. I think we are really doing good in terms of creating awareness for this World Mental Health Week. We had a series of sessions and today I think it's day for child psychiatry. At least, during the 6 months to 7 months of my practice, I being into a lot of child psychiatry, definitely, though we were looking at normal children, they're being at home due to lockdown and all that, but to look at children with autism, to look at children with ADHD, to look at children with intellectual disability, children with OCD. Their treatment was definitely, it was interrupted because of the lockdown, like the other adult patients. And definitely I could see that there are a lot of exacerbation of the symptoms, in particular in children with autism, ADHD, and parents had really tough time because many need interventions along with medication. But I think Dr. Rishi is there. I think he'll do a wonderful job. He's from Nilafar. I think we really need to look at his presentation. And Dr. Kesharov sir has definitely inclination towards child psychiatry. Dr. Ram Subbareddy sir also is there, professor at Nilafar. And Vishal also has specific inclination towards child psychiatry. I think we should throw some light focus which would help the pediatricians particularly who will be joining this program, so that they can have a bird's eye view about these issues, and at least they can try to intervene at there and then, or else try to refer to the mental health professional who can take care of the children in need. Thank you, Dr. Jagannath sir. Over to you, sir.
Dr. Keshara, without wasting further time, you can go ahead conducting the program.
Thank you, Dr. Jagannath. At the outset, I would like to thank the Telangana Psychiatric Society and IMA for giving me this opportunity to chair this session. And children's mental health problems are quite common. Most people think that children don't have any problems, but their prevalence of mental health problems is as much as adults. They also suffer from anxiety, depression, apart from developmental disorders, what we call as ADHD, autism, etc. But parents are very reluctant to bring the children to a psychiatrist's office because of the stigma attached and needlessly suffer for long. It is very helpful to interact with general practitioners and pediatricians in this way. And this is a very welcome move by IMA and Telangana Psychiatric Society together. I will introduce both the speakers. The main speaker, Dr. Hrishikesh, he did his MBBS MBBS and DCH from Gandhi Hospital, and he worked as a pediatrician for 6 years in government setup before joining MD Psychiatry at Usmania in 2012, which he completed in 2015. He is currently working as assistant professor in child psychiatry at Nilofar Hospital. He has conducted workshops on early screening methods in autism and has been awarded as Young Speaker from IPS South Zone in 2018. His areas of special interest are autism, ADHD, and SLD. I'm sure the person who is working both as a pediatrician and child psychiatrist, then awarded as Young Speaker, we are going to have a real treat from him. And our panelist, Dr. Vishal, equally dynamic and active. He's working as Associate Professor of Psychiatry at Government Medical College, Nizamabad. He did his MBBS from SVS Medical College in 2005, MD from Mamata Medical College, Khammam. Dr. Vishal is an active member of Indian Psychiatric Society and IMA. He is presently convener Public Education and Awareness Committee of Indian Psychiatric Society, Treasurer Telangana Psychiatric Society, ex-council member, Suicide Prevention Committee member of IPS South Zone. He is also assistant editor for Indian Journal of Psychological Medicine and Journal of IMA Orissa State. He is also working as General Secretary of IMA Nizamabad. So we have two very dynamic young speakers today. And I heard Dr. Ram Subbareddy is here. He did not submit his CV. I did not get a copy of his CV, but I know Ram Subbareddy was my long colleague. He was a professor of psychiatry, child psychiatry at Nilofar Hospital. Great experience in child psychiatry for many long years. So I'm sure he would definitely contribute to the discussion. And now I hand over to Dr. Hrishikesh for his talk. Dr. Hrishikesh, please take over.
Yeah, good evening all. Thank you, Kesharov sir, for the nice introduction. Before starting it, I would like to thank Indian Psychiatric Society, Telangana State Branch, IMA, as well as IAPP for giving me this opportunity. Being all my seniors, I feel Like I'm talking, I'm like a kid in front of all your seniors who was practicing so many years. But still, I try to put my effort to basically deal with all child psychological problems, which are more prevalent nowadays during pandemic, and they're all already there. But because of the stigma and less awareness, these problems are not that much recognized. And let's throw a light on what I'm going to talk. Basically, what is the definition of child psychiatry? It's basically it's emotional, behavioral, developmental problems which causes inadequate social and educational impairment in the child. So here there may be problem with the emotional development of the child, or there may be a behavior problem or issues with the development, like milestones, general milestone development, like speech, language, motor, fine motor, gross motor, and social and communication. Any deficit in all these domains which can impair the child's education and social functioning is child psychiatry, basically childhood psychological disorders. The domains can be individually affected, like emotional can be affected, either behavioral can be affected, or developmental can be affected, or all the three can be affected in one situation. So coming to the prevalence, the worldwide prevalence is around 7%, and it rises more in urban areas. Almost there is increase in puberty almost up to 3 to 4%. Most of the psychological disorders in children are usually divided into various categories. The most commonly defined categories will be externalization disorder, international disorder. What exactly is externalization disorder? Whenever child has some stress, whenever child has some issues to deal with, usually he'll externalize everything what he has. He'll be more irritable, he'll be disturbing others, he'll be breaking things, he'll be angry, vindictive. All these are called externalizing disorders, usually disturbed antisocial behaviors, which are up to 3 to 5%, which are usually noted. What are the internalizing disorders? When the same child has, some different child has stress which is not able to cope up, or issues with something, then he'll take all the stress to himself and leading to troubled emotions and feelings. The prevalence is around 2 to 5%. A mixture of psychosomatic illness is also seen, where the psychological problems are associated with the somatic symptoms, where the child complains of headache, giddiness, pseudo seizures, and all those things, which are also prevalent, which are called somatoform disorders. And almost overall prevalence of childhood psychosis is only 0.01%. So what are the common childhood psychological problems? So common childhood psychological problems are divided into various things. First, initially I told you about externalization and internal disorders. There are the common childhood psychological problems based on age specific, and are also what are the disease specific. One is feeding and sleeping problems, other one is behavior problems, the other one is emotional problems, developmental problems, and there are also normal concerns. Most of the parents come to us saying that my child is having some concern, whether it is normal or abnormal. There may be normal concerns which you have to deal being a child psychiatrist, where the parents come because the behavior may be literally more than what is expected for that age group. Sometimes it may be a normal behavior. And age specific, I'm going to divide into 0 to 3 years, 3 to 6 years, 6 to 12 years, and 12 to 18 years. So in common concerns in the 0 to 3 years will be normal concerns will be thumb sucking and head nodding. During this period, thumb sucking is considered as normal and head nodding is also considered normal. It will wane away by age as the child grows older and older. And in feeding, sleeping problems, there will be food refusal, feeding fads, there may be picky eaters, there can be pica where the child is eating non-edible substances like chickpeas, mud, and everything. And niter is also present during these periods. And emotional problems, sibling rivalry, when the child is around 3 years old and there is another child in the family who was recently born, and probably the attention shifts, all the attention from the parents shifts towards the younger child, that may cause sibling rivalry and started hatred in the child. This is a process of normal development which usually wanes out by the age as the child grows on age when you try to explain the child. And others are attachment disorders and behavior problems in our breath holding spells and temper tantrums and development delays. This is of this all these 0 to 3 years development. Delayed development of milestones is the one thing which you have to look into it, where there may be delayed in motor, fine motor, gross motor development delay, speech or language delay, or any regression causing autism. All these can be identified from this age group. Coming to the age group of 3 to 6 years, normal concerns are fears because they can't go to the bathroom when the light is switched off. They are not able to sleep alone in the room, in the dark areas. They can be afraid of dog. They can be afraid of some insects. All these fears are normal, which usually go with the age. Nail biting is also most common concern, with the parents say that continuously the child bites nails and eating the nails very much. That can be a normal concern during the period of 3 to 6 years, which usually improves by the age grows when you try to explain the child that why it is not healthy to do it. and nightmares are also present during this age. And coming to feeding and sleeping problems from that age group, bladder and bowel control, where the child passes urine in the bed, especially in the night, called as nocturnal uresis, and pass stool in the clothes, probably encoparesis. Enuresis and encoparesis are two problems which are usually predominant in this age group, because continent of bowel and bladder usually attained by three years of age. After 3 years of age, it may take 1 to 2 years more to develop proper continent if you are giving proper trial training. Sometimes they are not continent. There may be daytime enuresis as well as nighttime enuresis. If it is only present in nighttime, we call it as nocturnal enuresis, where the bladder control is not attained and child starts bedwetting, and bowel 1 year early to what bladder control should have been attained. In these children, some children will have passing of stools, soiling their clothes because of the passing of stools in the clothes. That can be seen abnormal at this age group. Emotional problems, what you see at this age group are separation anxiety, sibling rivalry, and anxiety disorders. And behavior problems are opposition defiant disorder, where which is commonly called as opposite defiant disorder, and temper tantrums are also seen. In developmental delays, speech problems like stuttering, stammering, development of speech language delays, intellectual disabilities, and specific learning disorders are also seen at this age group. From 6 to 12 years, school refusal, most common concern, which usually seen, most of the referrals come to us from IP department or OP department, or school refusals to Nilofer hospitals. There may be multiple reasons for school refusals. Simple specific phobia to not interested to go to school, or some did not do homework, some has some issues with teachers or friend or something like that. There may be so many issues which can cause school refusal, as can be detected at this age group from 6 to 12 years. Feeding and sleeping problems, which usually will go away by this age. And emotional problems which you see at this age group are anxiety, depression, obsessive compulsive disorder, conversion disorder, a type of selective mutism, phobias. And behavior problems is attention deficit hyperactivity disorder is seen from 6 to 12 years. And in developmental disorders, specific learning disorder and writing problems are also seen, can be identified at this age group. From 12 to 18 years, again it is school refusal. And next comes to peer pressure and parental pressure, which are usually normal concerns. Parental pressure and peer pressure about studies. Peer pressure is about developing new habits, can be smoking, can be developing drinking alcohol, or exploring new things, or high risk behavior can happen because of peer pressure. Parental pressure is all about studying and all those things. This can lead to stress in these children, can present with minimal problems not fitting into a proper diagnosis. This can be a normal concern during this period. And feeding problems, too much of junk food can be given, leading to obesity and other issues. And in females, most commonly eating disorders like anorexia are usually prevalent at this age group. In emotional problems, again, anxiety, depression, OCD, phobias, conversion disorders are usually seen in this age group. And behavioral disorders, ADHD, if you can't pick up at early age, can be picked up at later age group. ADHD can be present. And conduct disorders and experiments with drugs and other things can be seen at this age group only, because of high risk behavior and little immature mechanisms, coping mechanisms, where what is right, what is not right cannot be identified the child at this age group. And adult type of disorders can also be identified as early as 16 years. Schizophrenia can be seen, can be a possible diagnosis by 16 years of child, especially in male child. And bipolar disorders also seen. So this is according to the age group which is there, which I try to divide according to the age group. And this is the pictorial depiction of the same, which I try to divide infancy, preschool, primary school, and adolescence. What are the common disorders you expect along this age group? So coming to the categorization, whatever I've discussed is basically a simple form of psychological disorders, but there is a specific category of disorders to diagnose, particularly at that particular, if the child has features fitting into particular diagnosis. The categories are neurodevelopmental disorder, which includes intellectual disability, autistic spectrum disorders, attention deficit hyperactivity disorder, and disruptive impulse control disorders and conduct disorders, oppositional defiant disorders, intermittent explosive disorders, and conduct disorders. These comes under behavioral disorders. Feeding and eating disorders like anorexia nervosa, bulimia nervosa, and binge eating can be seen. In depression and bipolar disorders can also be seen, which are present with major depressive disorder, persistent depressive disorder, bipolar disorder, disruptive mood dysregulation disorder. Anxiety and obsessive compulsive disorders or other category, where separation anxiety, generalized anxiety, and OCD are seen. Trauma and stress related disorders are also seen, where reactive attachment disorder, disinhibited social engagement disorder, and post-traumatic disorder. These are the basic categories where the child psychological problems are divided, and these are considered to be a psychiatric issue which should be addressed by the psychiatrist, and if required, treatment should be given. These are the categorization. Now I'm going to talk individually about each disorder, the main disorders which usually we come across most of the children. First one is autistic spectrum disorder. What is autistic spectrum disorder? It's in vague, it's in rise now. I'm getting almost 2 to 3 cases per week at Nilufar Hospital. Most of the complaints, they start with speech delay. They come with complaints of speech delay. But when you go into the details, what are the core features of autistic spectrum disorder? The core features are basically social communication deficits. The deficits in communication where there is no social interaction. Social interaction includes social and emotional reciprocity, where the child is not emotionally responding when you are talking to him, not making an eye contact, not listening to you when you are talking, not understanding what your commands are, and there is no reciprocation. Duet communication is not there, where child is not responding whenever you are asking a question. All these things are not seen in autistic spectrum disorders. And communication is not about verbal communication. Non-verbal communication is also a type of communication which will be lacking in autistic spectrum disorders, where child will not have pointing out or asking for something, or looking at something or pointing out something and demanding something will not be there in children. If it is there also, it will be not to the extent of what the age development should be there. There also will be lacking. And child with autistic spectrum disorder cannot understand or maintain relationships. Probably he'll be attached to the mother, but he doesn't understand the emotional reciprocity with the mother. He only calls mother whenever is need, but regularly he doesn't communicate with the mother. And there will be restrictive repetitive behaviors, which are also called stereotyped behaviors, which are usually of motor stereotypes or vocal stereotypes. Motor stereotypes are most commonly flapping of hands, running here and there, rocking movements of the body, jumping at one place, rotating at one place. All these are motor stereotypes. Vocal stereotypes are repeating the same word on and on. If they pick up one word per day, suppose they start saying the, they keep on saying the from running here and there without any motor, without calling anybody, without trying to interact with anybody. And vocal stereotypes are also called echolalias. They are present, which is parroting. They repeat whatever we say. If we say what is your name, they also say what is your name, which is kind of parroting, usually seen in autistic spectrum disorders. And usually these children insist on sameness. Whatever they eat, whatever they play, whatever they dress, whatever the daily activities, they usually prefer to stick to the sameness. Most of them stick to the sameness. They don't have to be always somebody will stick to the routines of the day, somebody will stick to the toys they play with, somebody will stick to the dresses they wear, somebody will stick to the food they eat, though usually the fixed interest will be there. And there may be hypo or hyporeactive sensory input. That means all the sensory issues, sometimes they react very high to simple pain, like simple sound, like any foreign sound or grander sound. They close ears, they start crying, they'll be very frightened. But at the same time, if there is some big vessel fell in the house and made a big sound, they may not react for this in the same way. So they may be hypo or hyperacoustic issues in these children with autistic spectrum disorder. And at the same time, sensory input all the same. For simple pains, they usually react in very aggressive manner. For simple pinch or simple pinprick, they may cry very loudly. At the same time, if they get injured by knocking their head to some stool or something, and if the child is still bleeding, he may not react. So basically, the age group as early as we can identify autistic spectrum disorders are basically around 18 months of age, where the child doesn't communicate at all. Communication is not, again I'm stressing, not about just only speech. It is about non-verbal communication also, where there is no pointing out, no reciprocation. If you take a 9 months old child, if you try to talk to him, usually reciprocates with sounds. When you make a sound, when you call his name, he looks into the eye and makes a contact and responds to the name. But in these children, they don't do it. If you try to catch them and hold him, they usually take their eye from away you, or will be looking from the sideways. They won't have that proper social emotional reciprocity along with communication deficit. These are the core features which autistic spectrum is there. As you call it as a spectrum, there are many number of issues like sensory issues, stereotypes, which are many stereotypes which are present, sensory issues are present, but these are the core features which should be present to diagnose autism. It usually presents at 18 months of age. We can suspect by 18 months, can be diagnosed by 2 years of age by different scales which can be used and properly assessed, and intervention should be done. And what are the early suspicion sign of autism? As per the American Academy of Neurology, when can be autism suspected? If there is no babbling, like ba 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 da da, or any, or pointing out or gesturing, any gesturing like for signing for water or food, or any pointing out to pick up a toy or something, pointing out to show something is not there by 12 months, then you can suspect autism. No single words by 16 months of age. No single words. No spontaneous single words. Not repetition of words. spontaneous single words. He should not repeat. He should have spontaneous single word like amma, akka, tata, mama. Should be spontaneously saying that. If there is no single word by 16 months or no two spontaneous words, again, this is spontaneous word should be there, not echolalic. Echolalic, as I told you, repetition of whatever you say. That is echolalia. If there is no two spontaneous words by 24 months of age, then you can suspect autism. And loss of language or social skills, regression of milestones, regression of social skills or regression of language. Not all the milestones, language and social skills at any age you can suspect autism. These are the major signs to suspect autism as per the American Academy of Neurology. Coming to attention deficit hyperactivity disorder, this is the most common disorder usually seen, can be diagnosed around 6 years of age, will be prevalent from that age. Around 30 to 50% of ADHD will go into adult ADHD also. There is a proper diagnostic criteria to diagnose ADHD. Every children who is running here and there, jumping here and there is not ADHD. Parents come to us complaining that my child is not sitting, my child is not concentrating, my child is not listening, my child is not able to sit at one place, is very clanky, is breaking things. These are children are not ADHD children. For diagnosing ADHD children, there is a particular diagnostic criteria. So it should be properly evaluated. And if the child fits into that criteria only, you can diagnose ADHD. So I'm going to tell you the criteria, what exactly it is. At least 6 symptoms of the following 9 symptoms should be present for a period of more than 6 months, which affects either social, academic, or occupational functioning. So there should be at least 6 symptoms of the all 9 symptoms, and they should be present more than 6 months period, and they should be consistent with developmental age. Basically, whenever you assess a case of child psychiatry, the developmental age is very important. That is, the mental age is pretty important. Yeah, whatever the age group is you are assessing, initial mental age assessment is pretty important, because if you are assessing a child of 6-year child and the child's mental age is around 3 years, and you can't diagnose ADHD because 3 years is the mental age of the child, where you can't say the child is ADHD. So his mental age also should be around 6 years of age to diagnose ADHD. And it should affect his personal, social, and occupational functioning. So it should affect his academic performances. It should affect his uh, relations with peers. It should affect his family members, his relation with family members, his academic performance, all should be affected. Then only you call it as disorder. For calling it a disorder, there should be a dysfunction. And it is divided again into inattention type and hyperactivity type. So what is inattention type? Often fails to give attention to close details and does careless mistakes. How usually child present with it? This is the sentence given, but how usually child presents? Child presents with whenever he sit to do a homework, he knows the spelling, still he does careless mistake by not writing spelling properly. Whatever he's writing, he's not concentrating properly. He does careless mistakes. When you ask the same question, when you ask the same spelling about it, he will respond by orally, but he will not be able to write properly. He'll do the careless mistakes repeatedly, on and off, consistently. Children will do it occasionally, but these kids do very regularly, on a regular to day-to-day basis. Whenever you check their book, there will be so many spelling mistakes will be noted, and often difficult to sustain attention on task or a play. Whenever there is a play which requires mental effort, whenever there is something which requires mental effort like studying, reading, or something, they can't sustain their attention for longer duration. They usually get easily diverted. They can't focus. If they're studying also, they study for 1 to 2 lines, then they get distracted, again they start studying, they keep on taking the breaks before reading. So they can't put their sustained mental effort at one place whenever there is mental effort required. Here I like to highlight one point. Most of the parents come to me and say that my child can play video games for longer duration, they can use mobile for longer duration. How can you say the child doesn't have concentration? So it is not. Playing video game is not about concentration. Playing video game is not putting a mental effort there. Mental effort is something where he has to work on his brains to reason out, problem solving. All this should be there, where he has to understand the meaning of that, and also get the content what he has read, also should do an output to it. That is about concentration. Playing video game is not about sustaining attention or concentration, and often does not listen while spoken directly. Whenever you try to speak to the child, usually he doesn't face you. He'll be looking here and there, or he'll be walk away from middle of the conversation. Whenever you speak to these children, they usually walk away from you, doesn't listen to you completely, or they half listen and they go away and come back and ask you again, what did you say? Often does not throw on follow instructions. Whenever you give instruction to them, whenever you tell them to do something, or you give more than 2 instructions, they try to fail to complete the 2 instructions. They'll be doing the instructions they'll be stopping the instructions in between. They won't complete the instructions, or else they'll be doing incompletely whatever you have told them. If you tell them to bring two things, or do this and after that do that, he'll not be completing first task, he'll not be completing second task also, or if they do it also, they'll be doing incompletely, they'll not be finishing the task, and often has difficulty in organizing tasks and activity. Here the children usually, where they can't organize, in children basically we see organizing tasks about putting his books properly in the bag, whatever are required for the day. Every day in the class they require some books, some pencils, color pencils. If they have a drawing class, if they have a activity class or a play class, they need to take a football. If they have football class, they'll be poor in organizing this. They can't calculate, they can't organize them properly. If you say their bag, everything is pushed haphazardly. They don't have proper organization techniques. They always forget something. They always tend to bring extra things or forget something. Most of the times it forget things. They usually forget pencils, pens, books, or tiffin box or water bottle, which is required for the task which is required, and often dislikes whatever the whatever the act of mental effort is required. Often dislikes studying. Often dislikes the activities which the child has to have put mental effort. He usually dislikes whatever the activities which requires mental effort. Often loses necessary things for the task. As I told you, usually they lose pencil, pen, they lose book. They don't bring book back, or they'll bring someone's book. They usually loses pencil and pen, which are required tasks for the day, and often easily distracted. Here, when the child is doing some activity or some task or doing some homework, when he's sitting here, when there is a sound outside, or when there is something at the home, or somebody is talking in the kitchen, he easily gets distracted and looks at the other way, leaving this whatever he's doing. This is easily distraction, and often forgetful in daily activities. Whatever he's doing daily activities, he keeps on forgetting things. Whenever you tell him to bring something when he's come back from the school, whenever you tell him to do some task which is given as a homework, usually forgets and tends to skip the task and doesn't do the task. This is predominantly inattention. From all these 9 symptoms, there should be 6 symptoms which should be present for a period of 6 months to call it as ADHD, predominantly inattentive type. Coming to hyperactivity and impulsive type, in this, children often fidgets and taps their hands. Whenever they sit, they can't sit quietly. They have to fidget their hand, tap hands, or swims in the seat, moves around the seat, or pull something what is on the table. Whenever he comes to your clinic, or whenever you see him, he often pulls something on the clinic. He keeps on doing that. When you instruct him also, still he'll be doing that. Or if he's sitting quiet also, he'll be fidgeting with hand, playing with the hand, tap on the table or tap on his leg. He'll repeatedly doing that, and often leaves the seat whenever it is required to sit. So there are some situations where the child has to sit. For example, in the class, when the class is going on, child has to sit and listen to the class. These children with hyperactivity and impulsivity, they can't sit in the class. If, they keep on changing the place from one place to other place. They keep on asking the teacher to go to the toilet, and I want to skip the class and go out, roam and come back. Every period usually do that. They keep on moving from here and there and keep on disturbing others. Places repeatedly can happen in these children. Often runs about and climbs things which are where it is inappropriate. Whenever you go to a relative's place, children tend to play calmly or play with other children if there is other children. But in these children, without any disinhibition, probably they'll wait for 5 to 10 minutes. After that, they start running here and there, pulling whatever they're exploring everything, which the children are not supposed to do at 6 years of age. If the child around 3 years is doing, it's fine. But at 6 years of age, the child is continuously doing this period in spite of instructing him, probably which is inappropriate, can be because of hyperactivity. Unable to engage in leisure activities. He himself cannot play. He cannot occupy himself. Most of the children, if there is a single child, they try to play themselves by different activities. They talk to themselves. They build up so many things by playing themselves. But these children with hyperactivity can't play alone. They have to repeatedly disturb others, and they get easily bored. They have to change toys repeatedly. They have to move from one task to other task continuously so that they don't get boredom. They wants to keep them continuously engaged with one or the other thing, and that engagement is also not consistent. That keeps on changing. It is often on the go. How do you describe often on the go? As it is driven by a motor. If you give a key to the toy, how it runs continuously, the children will be like that, continuously running here and there without any obvious reason for running. They keep on running here and there. Often talks excessively. Most of the children, especially little older age group, have these complaints. Especially females, they have continuous talk, excessively talk. They say, we are getting headache, stop it. Still they continue to talk. They ask questions, repeatedly annoyed, keeps on talking. Hyperactivity can have in hyperactive children can have these complaints. Often blood cells answer without complete of question, where when you're asking a question, he doesn't listen to the whole question. In between only he answers the question before completion of question, whether it is right or wrong. That is basically impulsivity. Often has difficulty in waiting his turn. How do you see in these children? In normal situation, whenever you are playing a board game at home, you're playing supposedly you are playing a carom, 4 people are playing, and his turn is third turn. He won't be able to wait for his turn. He keeps on pulling. His striker want to play. He wants to pull the striker, and he wants to disturb the game, and he can't wait in turn. Whenever you go to some place, a zoo or some place where he has to stand a line, he doesn't have patience to stand in a line. Keeps on disturbing others, runs here and there. Doesn't have patience to sit or wait for his turn. Often interrupts or intruders. Whenever elders are talking, usually they go and talk in between without knowing what they are talking, and without and they say things very inappropriately which are not supposed to say also. These can be seen in children with hyperactivity and impulsivity. And out of 9 symptoms, 6 symptoms should be present uh, for a period of 6 months, which causes dysfunction, can be ADHD with hyperactivity. If both symptoms are present, in both inattention there are 6 signs, in hyperactivity there are 6 signs, then it is called ADHD combined type. This whenever you diagnose a case of ADHD, the symptoms should start below 12 years of age. If you are diagnosing case at 16 years also, the symptoms should start 12 years of age. To make it clear, if the 16 years old male has come to you, or female has come to you and saying that I'm unable to concentrate, I'm unable to do all these things, unable to fix things, unable to wrap up things, I'm unable to focus on my career, and if it is of recent onset, you can't say it is ADHD. The symptoms should have started before 12 years of age only. Then only you can say child is attention deficit hyperactivity disorder. If you're diagnosing a case of more than 17 years, only 5 symptoms in each domain are needed to diagnose ADHD. So coming to intellectual disability, most common presentation in our hospital, where there will be intellectual disability previously called as mental retardation, where the child will have low IQ, low intelligence. Usually clinical symptoms are delayed milestones. There may be delay in fine motor, gross motor, social or language milestones. It can be a single delay of motor delay, or it can be a speech delay, or it can be a global delay also. So they usually present with these symptoms, or poor ability to learn new things. Especially happens in case of mild intellectual disability when they cross first or second class, where they have to learn new things and we have to read paragraphs. They are not able to learn new things. This can be a sign of intellectual disability, where the child can be mildly intellectually disabled. Poor development of speech and comprehension, delayed speech or poor development of speech, or unable to understand whatever we speak, can be a symptom of intellectual disability. Poor self-help skills, where he's unable to dress himself, unable to eat himself, unable to take care of his bathroom and toilet and all those things. Toilet care is not there properly. He's not able to wash his hands. He's not able to care of self-help skills are lacking. Then it can be intellectual disability. Poor memory and poor scholastic performances. This can be a sign of intellectual disability, where the memory is poor. Parents, most of them come with complaints that my child is reading, but he is not able to remember. My child is reading, he is not able to remember everything. These are the complaints. The parents think that he's putting an effort, but he's not a remember. When you assess this, there can be a chance of intellectual disability. And poor concentration, because he's not understanding anything of his low IQ. Definitely, the child will not able to concentrate, will deviate from here and there, can present with poor concentration abilities. Sometimes there will be regression of milestones. In autism, we talked about regression of only social milestones, where there is only regression of speech or social speech and language skills and social skills. But here the regression will be in motor domain also. There will be speech language skill regression, along with the lack of walking. Whatever previous attained milestones are there, previously child used to walk, run, speak and everything, these all will be lost. This can be one of the sign of clinical symptom of intellectual disability. I'm only giving the indicators. I'm not giving the diagnostic criteria. I'm only telling you what are the points where you can suspect intellectual disability. In the same way about behavioral symptoms, intellectual disability can also present with behavioral symptoms. Most of the parents, especially coming from the rural background, they think that my child is not interested in studies. That's why he is not going to school or not studying properly. In these cases, most of the time present with these kind of symptoms, where the child is restless and impulsive, where the child is not sitting in one place, he's impulsive, he hits without knowing the consequences, he pelts the stone at people, he abuses people, he assaults parents. This can happen in these children with intellectual disability. Self-injurious behavior can also be seen, where he tries to bite himself, cut himself, or harm himself by headbanging, and all those things can happen. Disturbance and sleep and appetite can also be seen. Can present with recent onset of change in behavior, can also be seen in case of intellectual disability who are mildly intellectual disabled. Can present with seizures. In seizure case also, most of the cases, not all the cases are intellectually disabled. Few cases are definitely intellectually disabled when you assess them properly. Have congenital, multiple congenital anomalies, can be present with intellectual disability, can also present with visual and hearing impairment. So these are the core symptoms where the clinical symptoms are different and behavioral symptoms are different, where you can get the clue of whether the child is intellectually disabled or not. From there, you start evaluating about his intellectual disability and assess him properly by doing proper scales and IQ assessment. Then you will know what level of intellectual disability the child is at. And these are the red flag signs. Usually, I want to give it to red flag signs because there are pediatricians, general practitioners. Most of them, when I was a pediatrician, whenever some parent is coming to saying that my child is not holding a neck, I used to be like, it's okay, it will take time. Come, let's see whether it is happening or not. We'll wait for some more time. It is not like that. Basically, there are red flag signs which are mentioned in OPGAI also. So every child has to attain milestones according to that. According to the age group, especially if you see premature babies, that should be a correctional age group. These are few red flag signs which I want to put. No tracking of objects by 3 months. Whenever you put a light in front of the child and trying to move here and there, if he's not tracking, probably there may be an issue with his development. No head holding by 4 months. 3 months, usually 2 months they start, and 3 months they usually completely hold the neck. By 4 months, if he's not holding the neck, probably there may be a developmental delay. It can be a simple motor delay or global development delay. You have to look into it. It can be because of his nutrition level also, but you have to look into it. No social smile by 4 months. Social smile is mother comes and tell me he's smiling at me. But social smile is something whenever somebody tries to play with the child, he has to smile, reciprocate a smile with the child. That is social smile. Usually starts by 2 months and it should be completely established by 4 months. If he's not attaining by 4 months, then probably you can suspect developmental delay. No vocalization by 6 months. Cooing sounds are made by 6 months. Basically, coo, coo, coo. All these sounds are made by 6 months of age. If there is no cooing sound by 6 months, probably there may be a development delay. No independent sitting by 10 months. Child should sit independently, start sitting independently by 9 months of age. By 10 months, he should be doing it completely. If he is not doing it by 10 months, there may be a chance of child going into developmental delay. Not walking by 19 months of age. By individual walking without any support, child has to take few steps. Then if it is not there, there may be a developmental. Again, I'm saying when these signs are there, please look into the child, assess what is the issue. If it is a premature child, you have to do a correctional age, then assess whether the development is normal or not, whether his height and weight are normal or not, whether it is simple motor delay or simple social delay or a speech delay, or it is a global delay. Based on that, your assessment can be planned. And developmental red flag signs for motor milestones. These are other clues which I'm giving you. When the child is little older, predominance of in particular position. Whenever you make the child sleep or stand in one position or sit in one position, he'll be maintaining that posture in one position only. Continuously maintain that position in particular position because of spasticity or hypotonia. This may be a clue for there can be a development delay. Poor fidgeting movements. Whenever you look at the children, they keep on moving their limbs, all 4 limbs continuously. Especially if you take a baby around 6 months of age, below 6 months of age, when trying to before rolling over, they keep the all the 4 limbs in flexion posture and keep on moving their limbs. If there is poor fidgeting, poor movement of these limbs, then probably you can suspect there may be a development delay. Asymmetry of positions can be there. One limb, one up left limb, left upper limb, left lower limb is not moving properly, or always kept in one particular position, can be a clue for development delay. And for social milestones, poor babbling, lack of reciprocity, poor eye contact, no orientation towards sounds. Whenever you talk to him, whenever you make a sound, he's not turning that side. Poor response to name to the call at a little later age group can be a clues for delay in social milestones. These are all the clues. I'm not telling exactly the diagnosis, what are the problems they have. These are the clues where you can suspect a developmental delay. We usually postpone things. I usually tend to do postpone things when I was a pediatrician. But after I did my child psychiatry, after working in Nilofer, I learned that every milestone is pretty important, and red flag signs are pretty important to know whether the child has adequate development for that age or not. Coming to opposite deviant disorder, this is one kind of behavioral disorder which is usually seen as early as 3 years of age and the prevalence, almost an average prevalence of 3.3% is present, usually seen in families, disturbed families, single mother, broken families, abusive family, alcoholic father, neglectful child, child abuse. All these children usually present with these opposite deviant disorder, where the child is usually very angry, irritable, argumentative. For trivial issues, angry. Child getting angry is normal. Children usually get angry. That is normal. But without any issue or for a trivial issue, the angry is out of proportion what is expected, and his mood is always irritable, continuously cranky, irritable, doesn't get calm very easily, is always argumentative. Whenever you tell something to do, he says I won't do it, he refuses your orders, he completely disobeys you. And deviant behavior where a child completely does opposite whatever you say, you don't have to go there. There is a current plug, you don't have to go there and put in finger. He does that to irritate you. That is deviant behavior. He does exactly whatever your instructions are. These are deviant behavior, usually seen as early as 3 years of age, can be diagnosed below 9 years of age, present from 3 to 9 years of age. And they're also vindictive. Vindictive is something where they keep grudge. If somebody hits them, they'll keep it in mind and try to hit them back whenever they get an opportunity, or they hit them immediately. So all these are features which are present, and this is called disorder. These are usually seen in all the children. Basically few children or have these symptoms, but in these children the behavior is so consistent that it's on everyday basis, day-to-day basis. That's why you call it as a disorder. This is called a dysfunction, because dysfunctioning in family, dysfunction in parenting style, all this leads to childhood behaviors. So it is opposite deviant disorder. These are the indicators which I have provided to give a clue that whether the disorder can be identified or not. Coming to intermittent explosive disorder, where there are recurrent outbursts representing a failure to control. Here, the child is unable to control their aggressive impulses. There will be repeated outbursts. There may be verbal aggression, like abusive language can be there. There can be physical aggression, where the child hits elder people more than his age or breaks things at home. Initially, there won't be any destruction of property can be there. But within a period of 12 months, if there is 3 episodes where there is a destruction of property, probably you can suspect intermittent explosive disorder. And these outbursts are not always equal to the stimulus which is given, the stressor which is given. Tell him not to do something, but the reaction may be very exaggerated. Child may react in very exaggerated way than what the stressor is, what the problem with the child is. When you tell him to not to do like that, he may get very irritable, start breaking things, or comes and hits you. Verbal abuse can be there. Simple instruction what you are given is not to do something which is not expected from him. For that also he may react aggressively out of proportion of what is expected. And the child must be at least 6 years of age. If these symptoms are present, probably there may be a chance of intermittent explosive disorder. Coming to conduct disorder, which these are the indicators usually present, starts at young age, can be diagnosed post 9 years of age, and most commonly associated with other comorbid conditions like ADHD, ODD, speech delays, and all those things. And mind intellectual disabilities can also have conduct disorders. Here, the child will be persistent, disruptive, and antisocial behavior. What is antisocial behavior? Doesn't follow social norms, which are societal norms. In ODD and in intermittent explosive disorder, here the child behavior is restricted to home only. His destructive behavior, his aggression is restricted to home only, or to the relatives probably. But here in conduct disorder, it goes to the society, where the child will be very aggressive and picks up fight very easily and does not follow the rules of the society. He breaks the rules of the society. Which are social norms to be followed in the society will not be followed. He'll be very defiant, spiteful, vindictive, revenge-taking type, very aggressive towards people and animals. Most of the common complaint we see is, when I ask if I want to ask a case, children's conduct disorder, how the child is with the dog, they say that he keeps on irritating the dog. He pulls the dog. He ties some stones to the dog. He hits the dog. He pelts the stones at the dogs. All these things can happen. Even I've seen kids where they kill lizards in the house. They capture and kill lizards in the house, and they enjoy it. They don't have remorse of doing it. They enjoy doing it. They keep on doing it. So any cruelty towards animal, cruelty towards people, they're hitting people, and they don't have remorse of hitting them, can be because of conduct issues. Vandalism will be there. Fire setting, whenever they get a chance of having a matchbox in their hand, they start setting the fire without knowing the consequences. It may be their property, others property, they start doing that, and destroying other properties can happen. truancy, which is like they say that they are going to school but they don't go to school, they roam around, which is truancy. Lying, pathological lying will be there, and stealing things will be there. Stealing is so much simple. Stealing usually kids will do like 5 or 10 rupees, but these kids start stealing more and more money, more and more money, hundreds, thousands, which are inappropriate for that age to steal. And when you ask them, they don't have remorse also most of the times. And they act in groups, they form a group and they start fighting, picking up fights with others. They usually act in groups most of the times, that is up to 80%. So alone acting is only 20%. I told you they are mostly associated with hyperactive disorders, learning problems, and there may be low self-esteem and depression. Sometimes they may be run away from home. Basically this the I don't know the word can be used or not, childhood ASPDs, where the child, if not treated or detected early, they can go into adult ASPDs. Like criminality behavior can be developed in these kids if you don't pick up early and treat them early. These are the clues for diagnosing conduct disorder. And I want to put this, basically these are the things which are not highlighted in any of the child psychiatric disorders, which are mostly neglected. The presentation will not be typically as you see in adults. Children will be presenting various kinds. They can present with depression, they can present with low self-esteem, they can present with irritable mood, they can present with stress. So I want to add this slide about feeding and eating disorders and create awareness about in general people where who are listening to the class. This again divided into anorexia nervosa, bulimia nervosa, and binge eating. What is anorexia nervosa? Restriction of food intake leading to significant body weight loss. If you see the image, they will be thin, emaciated. They restrict their food, whatever they eat. They eat in very little quantity. Here the issue will be they think that they have a body image disturbances. They think that they are very fat. Though they are emaciated and thin, they are very fat. Still they don't eat properly, they neglect to eat, and if they eat also they try to vomit sometimes. The vomiting is not severe, they usually limit eating most of the times, they eat very less in quantity, and they have intense fear of gaining weight or becoming fat. That's why they keep on restricting the food. And these cases, most of the cases, these will not present to psychiatric department. These are all the case of medical emergency department, because they are thin, emaciated, they have electrolyte disturbances, they have low sugars, they have failure to thrive, they don't have adequate expected weight for their age. Usually these are medical emergency. Whenever they come across these kind of children or adults, when you look at them, probably we have to look into anorexia nervosa, a condition, possible condition, which to be ruled out and dealt properly. And other one is bulimia nervosa. The indicators are here, the recurrent episodes of binge eating will be there. Here they eat with amount which is required more than what is required continuously. There won't be control what they are eating. They continuously eat. After they eat, they feel guilty and they start vomiting. Self-induced vomiting can happen, or use laxatives to pass motion and lose weight, or misuse of diuretics to lose excessive water. And fasting can be there. There can be continuous fasting for 4 to 5 days only on liquid diet, or excessive exercise can they do to lose the weight. They initially eat more than what is required, uncontrollable eat will be there. After that, they feel guilty and they do all these things to remove whatever excess what they have eaten. So this is also body think that they are more weight than expected, and it is followed by cycles of binging and purging. They eat, they vomit, they eat, vomit. They occur once a week for at least for a period of 3 months. Then you can probably suspect bulimia nervosa. These children or adults will not look emaciated, but they are underweight, not as much as you see uh, anorexia nervosa kids. They are expected underweight will be there. There will be definitely anemia, other conditions will not be there. They will not be serious, but when you ask them history, they usually present with depression or anxiety. When you go back to the history, probably you can find all these things like binging and purging and body image disturbances. This is binge eating disorder. Here there won't be any purging, there will be continuous eating, and after that they feel guilty about what they are eating. They eat uncontrollably, excessively. They eat without any control what they are eating. Until the stomach gets full, they are uncomfortable. They eat in large amounts. When they are not feeling hungry also, they eat. This can be because of low self-esteem, can be because of depressed and all those things. After doing this, again they feel guilty and depressed about this episode. And this episode usually occurs average at least once in a week for a 3 months period. If this is occurring this regularly, probably you can suspect binge eating disorder. And coming to major illnesses which are usually present in children, most common major psychiatric disorders, most commonly present in adults and as well as children. In children also, they are present with same symptoms. I'm not telling about any diagnostic criteria. I'm just presenting the symptoms what they are present. Usually they present with depressed mood or irritable mood. The difference between presentation in adults and children will be, if you take adolescents, they have depressed mood. But if you take younger age children, as young as 7 to 8 years of age, they'll have irritable mood most of the times. Diminished in interest in activities, decreased pleasure in activities, weight loss or weight gain can be there, insomnia or hypersomnia can be there. They can have lack of sleep or excessive sleep can be there, decreased activity, or they can be excessive activity because of irritable mood. Decreased energy levels will be there, feeling of worthlessness or guilty will be there, diminished ability to think and concentrate in studies, and recurrent thoughts of suicide ideation, attempt or plan can be there in depressive disorders. Where here the children, what exactly, how the children, these are the common symptoms usually children present. When you approach, when a child comes to you with these complaints, whenever the child approaches, probably the complaint most of the times will be, my child is very irritable, my child is not able to perform in the school, my child is not eating properly, my child is not sleeping properly, or else he's sleeping excessively, or else he's eating excessively, or else he's always keeping things to himself. He prefers to stay alone. Whenever you try to talk him, he keeps on weeping and is not able to study properly, and occasionally express ideas of death. All these can be clues of a depressive disorder. So there is a diagnostic criteria to diagnose depression, but if you find any of these symptoms in children, probably you have to suspect there may be a depression. There can be different reasons for all these reasons, but depression can be one of the possibilities. I'm not telling you, once again repeating, I'm not telling the diagnostic criteria. I'm telling you only the indicators of depression, what the child can present with. Anxiety disorder indicators. Most commonly children, as per adult, they can't explain, children can't explain that. When you see an adult anxiety client or a patient, they say that I'm feeling anxious, I'm feeling restless, and I'm able to sit at one place, my hands are shivering, there are increase in heart rate, my stomach looks empty, I feel like I'm floating in the air, my body became weight, my head became heavy, I'm feeling giddy. All these are complaints usually you see in adults, but in children they may not be typical complaints in anxiety disorders as you present in adulthood or adolescent. In children, they can present in different ways. The physical complaints most commonly can be repeated headaches, GA upset, repeated pain abdomens, or dramatic things can also happen, like pseudo seizures, falling off, jumping at one place, reeling sensations, repeatedly falling in school. Pseudo seizures can be seen. All these physical complaints can present in children in anxiety disorders. There may be sleep disturbances, change in eating pattern. Usually they start avoid outside people. Previously the child used to go and play outside and used to interact with kids. Now he is not interacting with anyone, he wants to stay at home, not going outside. Poor interaction with other children can be there. Then probably this can be a clue for anxiety disorder. Excessive need for reassurance, repeatedly asking that I'll be fine, whether I'll be fine, if I go to school everything will be fine, is there something bad going to happen, is there something bad going to happen to Pa, or is something bad going to happen to me, is there something bad happen going to outside, especially in this pandemic situation. Probably these are the usually complaints, they say that something bad going to happen. And excessive need of reassurance, repeatedly asking the parents that everything may be all right, everything will be all right. This can be a sign of anxiety disorder. And inattention and poor scholastic performance because of anxious traits. And these symptoms may not be always present. Sometimes the child may be normal functionally, the deterioration may not be that much affected. In some cases he'll be playing very well, he'll be acting very well, but to coming to some situation he may not be fine. So that's seen in his case of specific phobias. And like sudden explosive outbursts can also be seen. Sudden explosive outbursts of irritable mood, sudden explosive outbursts of cry can be seen as an indicator for anxiety. One second, it got stuck. So what are the other indicators? Repeated complaints of headache and stomach aches, early morning sickness, frequent urge to urinate and defecate, shortness of breath, breathing difficulty rather than shortness of breath. They complain that I'm unable to breathe, I'm not able to catch my air, there is some difficulty in breathing, repeated chest pain, tachycardia, that he is able to feel his heart rate, repeated vomiting or choking like episodes, difficulty in swallowing solids, dizziness. There is unexplained tension or exhaustion in the children, avoidance of present any of these symptoms can be indicator of anxiety disorders. So when these symptoms are present in children, probably you have to evaluate it properly with proper diagnostic criteria to diagnose anxiety disorder and act accordingly. So obsessive compulsive disorder, this is presence of obsession and compulsions, where obsessions are predominant, recurrent, persistent thoughts of their own, which are useless, intrusive, and worthless thoughts. Useless thoughts which are not important at all. There are repeated thoughts to the child. For example, recently I have seen a child. He says that whenever I see a God picture, whenever I look at him, I get all bad words in my brain. For that, he has to uh, pray to the God immediately. Otherwise, he'll be punished. He gets this thought repeatedly, and somebody gets his hand may be infected. That's why he walks continuously. So that is a thought which is present, which is his own thought, which is recurrent, and unable to control his own thought, which is unmanageable at times, and it becomes so unmanageable that child will be very irritable or very depressed, and he becomes very cranky and keeps on doing the same thing on and on. These are thoughts. When it comes to compulsion, there should be action. There is a thought of contaminating his hand. This is a thought. The compulsion is washing his hands. There is a thought of this, and then again the compulsion is washing hands. There may be so many kinds of obsession and compulsions. If you notice a children with repeated thoughts saying that I'm not able to remove this thought from the brain, this is continuously silly thought which is coming to the brain, and unable to control this thought, and this is worrying me a lot, and unable to concentrate on everything because of this thought, and spending more time that, probably you have to suspect there may be a OCD, obsessive compulsive disorder. For that, again, you have to take an expert opinion and do a proper examination, evaluation for diagnosing OCDs. Then proper treatment can be given. And it is not thing that it is only seen in adults. It can be seen in children also. So I want to add these slides also. Recently, the use of drugs. Use of drugs as predominant is given. There are different diagnostic criteria: alcohol dependency, substance use dependency, ganja, opium. All these dependency are there. But I don't want to go into the details of drugs. I want to tell what are the behavior changes that can be noted in adults when there is a use of drug. What are the common changes you notice when you can suspect the child is having drug usage? Change in scholastic performances. There may be falling of grades can be there, skipping of school can be there, tardiness where he's not maintaining his cleanliness, he's wearing the same old clothes, not bathing regularly, not taking care of himself properly can be there. Change in peer group. He used to have previous friends. Now the different friend groups are there, and the friends are also little older than him, and who you have noted in your area can be kind of antisocial group, can have friendship with them. Breaking rules at home. When you keep a social home rules at home, he's repeatedly breaking them. Occasionally children tend to break, but in these drug users, they can be repeatedly breaking the home rules which is required, and repeatedly breaking school rules, going away from school, and in community also they are picking up fights, abusing and assaulting others under the to possess the drug, to get the drug, or under the drug influence. They can do in both ways. Extreme swings can be there, increased irritability and negative attitude towards life can also be there, and sudden increase and decrease in activity levels can also be there, and withdrawal from family, keeping secrets. Previously child used to sit with everyone and eat with everyone. Now he's not sitting with everyone, sitting alone in his room, locking his room alwaysly, keeping everything secretively, can be a clue for using drugs. Change in physical appearance like loss of weight, loss of cleanness, strange smell because of the drugs they use, red, watery, and glassy eyes, running nose, allergies which were not usually there in the child previously, and changes in eating and sleeping habits are usually present. Lack of motivation of interest to do anything, lack of going out, lack of interacting with friends, lack of doing any hobbies previously used to do, lack of exercising, lack of going out parties. He's always preoccupied with possessing the drug, getting the drug, and using the drug. Lying and stealing and spending excessively amount which is more than his pocket money. For possessing the drug, he may steal and get that money for possessing the drug again. Using street drug, using foul language which is picked up from the streets, and increase in cigarette smoking also can be a clue for drug use. I want to also again highlight on the clues about social risk factors. What are the risk factors which usually present? What makes the adolescents or children or adults go for a suicide risk? If you have these factors, there may be a chance of the person going to suicide. One is mental illness, psychiatric, predominant mental illness like schizophrenia, bipolar depression, substance use disorder. All these can have high risk of suicide behavior. Any family history of suicide or exposure to suicide or family history of mental illness or family stress can be a high risk for suicide behaviors. Physical and sexual abuse, recent losses, financial loss or loss in a family, death in a family, or or loss of a relative, loss of a close friend. All this can be a suicide risk factor. Aggressive behavior and impulsivity can be a clue. This aggressive and impulsive behavior can commit suicide whenever they get an idea of committing suicide, because they are very impulsive. They don't think about consequences. Lack of social support, social isolation, poor coping skills, easy access to things which can harm themselves, uh, difficulty in dealing with sexual orientation, increasing cases of seeing that gender dysphoria cases are increasing these days, not increasing probably because of awareness. Probably we are finding it more. In these cases, when there is a discrepancy between parent and child or adolescent, there may be a chance of committing suicide. Any chronic physical illness can be a risk factor, or family disruption, divorce in the family, death in a family, or family abusive family can be a risk factor, or any traumatic event in life can also be a risk factor. Suicidal warnings. What are the warning signs usually we see in suicide? Preoccupation with death, recurrent themes of death, and he's talking continuously about death can be a clue for the child may or adult may commit suicide. Intense sadness or hopelessness. Whenever you look at the child, he may be completely sad and he feel hopelessness. Whenever you talk to him, he doesn't want to interact. He says that I'm hopeless, I don't want to live. Not caring about other activities, like previously he used to have some hobbies or go out, interact with friends. Now he's not doing it. Social withdrawing from everybody, from sports, from his hobbies and everything. Increased substance use, sleep disturbances, risky behavior, lack of energy, inability to think clearly or concentration problems, declining in scholastic performances, increased irritability, or change in memory. All these can be a warning signs, especially in adolescent people, can be a warning signs for suicide. This is not a proper diagnosis. These are only clues I'm telling you. These are all the clues which can be identified so that we can prevent the suicide. I don't know whether it is important for that other things or not. Assessment. How do you assess the children whether there is a psychiatric disorder or not? There are so many things we have to look into it. What is the reason for referral? What is the problem? Past problems, any comorbid symptoms, previous assessments are done or not? What is the child's development, family history? Everything should be kept in mind. Medical history, child strengths and weaknesses. This helps when you are doing a therapy for the child, and how the support of the child is there. Or what is the support? So environmental support, how the child support from the adults is getting, and mental status examination. These all should be done in the assessment of children to come to a diagnosis and plan for the management. What are the do's? Usually, what are the do's? Whenever you are interacting with a child, what are the things you have to do? Be empathetic to the child, where you understand, where you say that you can understand the child properly. You're there to help him. Introduce yourself as you're a helping person. Build a rapport with him. Building rapport can be done by different things. If an adolescent, you can talk to him about his hobbies and all those things. If it is a young child, probably you can play with him. Along with play with him, by play therapy, you can build a rapport. Understands child intellectual ability by assessing him. What is the child intellectuality? Then only you can understand the child psychopathology. If you understand his mental age, explain the purpose of interview. Why are you doing? Encourage the child to talk. Use open-ended questions. Don't most of the children, what happens is, when you want an answer from the child, you tell him the answer indirectly. Then the child thinks that my probably the doctor wants this answer only. He'll give you the answer what you are expecting. It should not be like that. Most of the times it should be open-ended questions, and be playful with the child during the interview, and give the child time to answer rather than rushing in. Give the time till, and if not this session, probably next session he may open out. These are the things that should be done during the interview of the child. What are the don'ts? Don't be judgmental. Don't come to a conclusion that he is doing this voluntarily. I'm seeing most of the cases referral coming from different places or different pediatricians, because pain abdomen, recurrent pain abdomens, they come with complaints saying that this fellow is doing voluntarily. Don't be that judgmental. It can be because of some issue the child want to express. It can be as major as sexual abuse also. So don't be judgmental, saying that this is his child is doing voluntarily. Don't rush in the interview, as I told you previously. Avoid suggestibility. Don't use negative statements, and don't threaten the child or confront the child. This is the major issue. Don't threaten the child and confront the child. Most of the time what they do is, when you don't get answers, you get frustrated saying that you will be given an injection, you will be thrown in the dark room, you will be sent to hostel. All these things usually said to the child repeatedly, regularly by the parent, by the teachers. And if we do that also, the child thinks we are in the same group and he would not open up. Don't continue or postpone the interview if the child is uncooperative. Whenever the child is uncooperative, don't try to force the interview. If you force the interview, it will lead to negative rapport establishment, and next time the child will not open up at all. What are the cues to suspect psychological illness? There are some cues for any age group to suspect psychological illness. Any decline in poor scholastic performances or any decline in drop-off grades will give you a clue the child may have some psychological. Recent onset of poor scholastic performances or overall poor scholastic performances or recent drop in grades can give you a clue. Disturbance in sleep and appetite, recent onset of persistent bladder and bowel disturbances, frequent complaints of physical complaints, recurrent headaches, recurrent stomach aches, recurrent giddiness can be a clue for psychological illness. Regression to childlike behavior, where the adult is there, now he's talking like a child, his voice has changed, he's behaving like childish behavior, he's clinging more to the mother, previously he's not used to do, he's actually worried, he doesn't want to leave his father, he's overly attached to the father, which previously is not to do, can be a clue for psychological. Recent onset of any change in behavior, child has a particular behavior all the through, suddenly there is some change in behavior you have noticed in the children, recent onset, which is persistent most of the times in a day or most of the days in a week or most of the weeks in a month, probably that can be a clue for psychological illness. You have to look into more detail to know whether there is a actually psychological illness there or not. Age inappropriate behavior, if the behavior is any age inappropriate, probably that also can be a clue for the child have some psychological illness. So these things probably will be dealt by my seniors. By the pandemic, the children, what are the things that to be taken care during the pandemic? Dr. Ram Subba Reddy sir and Vishal sir will be talking about. So I won't be discussing on these slides. Thank you very much.
Thank you. Thank you, Dr. Hrishikesh. Hello, am I audible?
Yes, sir.
Yeah. It's a very elaborate presentation in a short time. Dr. Hrishikesh has very nicely covered age-wise distribution, and then he mentioned about category-wise, and then he went on to describe autism, ADHD, intellectual disability in quite a good detail, and then also covered the remaining topics. A very excellent presentation by Dr. Hrishikesh. Before going to panelists, I would like to add for the benefit of our general practitioner friends that children usually present with multiple problems. Comorbidities are very common. For example, a child may present with a conduct behavior, but then we have to assess him for ADHD and IQ problems. Similarly, a child may come with anxiety, and we may have to look for problems like autism. So,
can you please stop screen share, Rishi?
Sir, I'm stopping it, sir. 1 second,
hello.
sir.
Yeah. So, as a child psychiatrist, sometimes I find it problematic to convince the parents to have these assessments, because parents say, okay, my child has a diagnosis of ADHD. Why are you asking for IQ? Particularly IQ tests no parent likes. But sometimes the concentration problem may be because of IQ issue. So usually the child psychiatrists have to do multiple assessments, unlike other specialties. So I just want to make it a point. Now I request Dr. Vishal and Dr. Ram Subbardigaru to say a few words. We have a shortage of time. Actually, we got 15 minutes. So if you have a few questions, if you take 5 minutes each, then we have one question from Dr. Shyam Gupta. We will take that question. Hello, Dr. Ram Subbardigaru or Dr. Vishal?
Sir.
Are they able to come?
Yes, sir. Yes, sir. Good evening, all.
Are they able to join?
Sir, good evening.
Yeah, good evening, Vishal.
Good evening.
Go on. Quickly. You got only 5 minutes.
First of all, I would like to congratulate and thank organizers, IPS Telangana State Branch, President Dr. Jagannath sir, and IAPP President Dr. Jaj Reddy sir, and IPS TSB and IPS Telangana Secretary Minaj sir. And Dr. Rishi presentation was excellent and informative. And Chairperson Dr. Keshav sir is expert in child psychiatry. I have attended many seminars, sessions of Dr. Keshav sir. Today, panelist Dr. Ramsubareddy sir giving good child psychiatric services in Nilofir Hospital. So during pandemic, I have seen many cases with psychological problems like online game addiction, like PUBG game related suicide attempts and depression due to lack of interaction with their friends. Some of children are suffering with depression due to loss of parents and relatives. So if chairperson permit, I would like to speak in Telugu language, sir, to for audience.
Only few minutes, Vishal Garu, because I think we have to 9:30 probably it gets disconnected. So you
నిజాం
got
కదా
only.
సార్, నేను యాక్చువల్గా సార్ ఇక్కడ కొన్ని టాడీ విడ్రాల్ కేసెస్ పాండమిక్ లో సార్ డ్యూ టు లాక్డౌన్ ఎఫెక్ట్ వలన చాలా మంది పిల్లలు సార్, ఎందుకంటే ఆ టాడీ అవైలబుల్ లేక ఫిట్స్ సీజర్స్ తో సఫర్ అయ్యి చాలా మంది రావడం జరిగింది సార్. అండ్ డ్రగ్ ఎస్పెషల్లీ యంగ్ చిల్డ్రన్ సార్, కెనాబిస్ అడిక్టెడ్ చిల్డ్రన్స్ పాండమిక్ లో లాక్డౌన్ లో వాళ్ళు స్కూల్స్కి వెళ్ళినప్పుడు అడిక్ట్ అయిన వాళ్ళు ఇంట్లో ఈ డ్రగ్స్ అండ్ ఈ డ్రగ్స్ ప్రాబ్లమ్స్ ఉన్న వాళ్ళు కూడా చాలా మంది రావడం జరిగింది సార్. సార్, ఐ వుడ్ లైక్ టు రిక్వెస్ట్ IPS TSB and IAPP Telangana State Branch. So please prepare some posters, sir. చాలా మంది స్కూల్లో టీచర్స్ అండ్ పేరెంట్స్ ఇందాక డాక్టర్ రిషి చెప్పినట్టు సార్, అసలు డిఫరెన్స్ ADHD, ఆటిజం అండ్ మెంటల్ రిటార్డేషన్ డిఫరెన్స్ తెలియట్లేదు సార్. సో IPS TSB should take initiative and prepare the posters in all schools, sir. ఇది schools లో మనం ఫేస్ చేసినట్లయితే చాలా మంది అవేర్నెస్ వస్తుంది సార్. This is my suggestion, sir. Thank you, sir.
Thank you, Vishal. Very good suggestion. Particularly, you mentioned about internet addiction, which is actually a major problem nowadays. And actually, most of the time, parents bring the child and they say, "Please counsel our child." You cannot. You have to counsel the parents. Say the parent training is the most important thing. And many parents think that they leave the child with the counselor, and the counselor will make the child all right. It is not going to happen. So the parents have to know the behavioral techniques and change the behavior of the child. Okay, thank you very much, Vishal. Dr. Ramsubareddy garu, please add few words to Dr. Ramsubareddy garu. Unnara sir akkada?
Sir, voice mute, unmute చేయండి sir.
Ramsubareddy, sir.
Unmute చేయండి sir. Ramsubareddy sir. Unmute. Yep.
Okay.
Yes, sir.
Yeah, yes, sir.
Dr. Hrishikesh covered extensively all the psychiatric problems, from developmental milestones to eating disorders and feeding disorders and all the things. I think it is difficult to understand all the psychiatric problems in one session to all the practitioners or pediatricians, whoever it may be. Maybe pediatricians, they can understand a little better, but the psychiatric PGs, they can understand. But say in a single session, it's very exhaustive. But okay. The problem here is just now Keshav sir pointed out. Say some people, they are objecting to do IQ for ADHD illness. So if you don't do IQ assessment for all the patients, whether IQ, whether autism, ADHD, whatever it may be, we have to, first of all, we should do IQ assessment. Then only we'll come to know whether it is due to the mental retardation, all these inattention or decreased concentration. It's difficult to assess. So you see, regularly we follow in the Nilofar hospitals all these IQ assessments. So regarding these developmental milestones, Dr. Rishi covered very well. And some of the pediatricians in the private practice who are practicing outside, they are assuring to the parents the child they develop language after 4 years or 5 years. That's why the children are getting delayed. Parents are getting delayed to bring the children to the Nilofar hospital. Many times we have seen such type of cases. After coming to the Nilofar hospital, they improved very well. But even if they send within 3 months, 3 years, it will be good for the children. We can improve them better. So coming to the pandemic, it's very difficult to control the children because their energies are very high. We have to ask them to play the games in the rooms or in balconies, or we have to take them to the local parks in the protective environment by the parents. We should not leave them alone. So most of the times, if you stay alone continuously for 4 months or 5 months in the indoors, they may develop some psychological disturbances like emotional disturbances, irritability, anger, all these things. It's very difficult to treat. Sometimes they may land in PTSD also, post-traumatic stress disorders. All these stress disorders is very common in the natural disasters, car crash, or some of these things, physical abuse. So in this case, the physical disturbances, PTSD, one has to tackle immediately, otherwise they may land in panic attacks. The PTSD symptoms, if you don't treat immediately, because the hyperarousal states, continuous hyperarousal states in PTSD, they may land in a brain damage if they continue for longer periods. So with this, I complete my suggestions.
Thank you, Dr. Ramspardi garu, for covering the psychological consequences of COVID illness. I take up Dr. Shyam Gupta's question straight away. Psychological problems. Do psychological problems leads to schizophrenia and mania? Sir, this is a common question asked by many parents and family members. Psychological problems play a role in causation of mental illnesses, but different mental illnesses have a different degree of causation. For example, in anxiety disorders, probably psychological factors play, or thinking plays a major role. But coming to depression, yes, probably psychological factors do play a role in causing depression, life circumstances. But coming to severe mental illnesses, like schizophrenia and mania, the role of psychological factors are much less. Probably they may appear at the time like a precipitating factor, but we consider them as not at all, not of much importance. This parents have to understand, because one, it will remove any guilt on the part of the parents. So it has nothing to do with the parenting. So there is a huge genetic overlay in the causation of these disorders. Family members may not be able to find an illness in the previous family members, because the illness may be in a milder form or an attenuated form. And in the previous generations, mental health was not such an issue. In a village, a person with some intellectual problems or deficiencies in the functioning can continue his agricultural activities, and the joint family used to take care of him. So the diagnosis was much less in those days. So I would like to say probably no, psychological factors are not very important in schizophrenia and mania. And we have to also understand what is like in diabetes. Suppose someone has got a very high risk of developing diabetes, and if he does good exercise, good lifestyle, probably he can postpone it a bit later. The same thing happens in the mental health also. So stress may contribute a little bit, but it is not just stress. There is a vulnerability also. So that's what we call stress vulnerability hypothesis. If there are any more questions, I saw only one question. Can I ask Dr. Minhas, sir, any questions there? Any
Sir, one more question is
question
there.
answers?
Is ADHD linked to bipolar disorder?
Yeah, I will transfer this question to Dr. Hrishikesh, the main speaker. Dr. Hrishikesh, can you answer that question?
Basically, ADHD and bipolar disorders are most commonly one of the comorbid conditions which usually exist in children. They can be a comorbid conditions, but there is a minor difference between ADHD and bipolar disorder. So you have to differentiate between ADHD and bipolar disorder. So in bipolar disorder, there won't be so much of hyperactivity. There will be excessive increased self-esteem, boastful talk. Most predominantly look into is decreased need of sleep, which I have seen most of the cases. I have seen few cases of ADHD presenting as bipolar disorder. Once we treated bipolar disorder, ADHD was remaining. So in these presentations, what was there was excessive speech was there, but decreased need of sleep was not there in ADHD. In ADHD, children tend to sleep. They have sleep disturbances. They sleep pretty late, but they sleep well. But in bipolar disorders, they don't sleep at all, and they don't have that boastful talk or increased self-esteem and increased activity, which is out of proportion of what is sleeping, what is eating. Probably this is a differentiating pattern, but they may coexist usually.
Dr. Hrishikesh, I think the question asked was a very deep question, and nowadays there has been genetic link found out between ADHD and bipolar disorder. So I think the person who has asked question was asking about this too. So yeah, there is some genetic link. We have not located the gene, but definitely there is some gene between which is shared. Like some circuits are same in ADHD as well as
And
bipolar
bipolar.
disorder. I think
Even
I have answered
20%
the
of the
question.
ADHD people, they may turn into bipolar affected.
Bipolar disorders.
20% is common. It's
Thank you.
clear.
Okay. I see
One more
another
question.
question. Yeah. Please answer that one, Rishi. Is
So
conduct disorder?
basically, conduct disorder, if it is very severe enough, causing trouble, probably low dose antipsychotic. Initially, low dose antipsychotics are helpful, especially second generation antipsychotics, where they decrease the irritability, impulsivity, all these things there. Along with combined with behavior modification and behavior therapies, will reduce the behavior. Usually, most of the times, it will come down if you handle it properly. Good parenting, social support, psychiatrist and psychologist help for therapies, and medication for psychiatrist will give you a good result.
Can I add to this? Any child with conduct disorder, you must look for ADHD. Even in a country like UK, I have seen children who are interned in a kind of mini prisons. They actually had ADHD, but that was missed because everyone thought the child is naughty, bad boy, and all that. Many 50% of these children probably have ADHD, and if you correct that, there may be a big improvement. Any questions? Any more questions?
Sir, if you permit, it will not be a question, but a kind of
A comment. Yeah.
comment, sir. I think Dr. Rishi, you did a wonderful job. I think to all the youngsters who are watching this program, particularly psychiatrists, the child psychiatry is evolving actually. Basically, I think Rishi didn't have time to even look at the pharmacotherapy. I think we are trained in terms of pharmacotherapy. There's a lot of evolution and new molecules coming up, and definitely I think we need to explore. And for those who have time, definitely learn the basic principles of behavior therapy, so that you can do all in one, or at least refer to therapist. But pharmacotherapy is doing really good, particularly in almost all the conditions. Like Rishi was talking about conduct disorder. Yes, low dose of aripiprazole works well, actually. And but if you have the inclination and you have the taste to practice child psychiatry, time matters a lot. You should be able to sit and you should be able to learn the basic principles of behavior therapy. And particularly if autism is there and intellectual disability is there, you need to have a good liaison with the professionals, like the psychologists, the occupational therapists, the special educators. They all play a role because it's a teamwork. But as a psychiatrist, please, you need to look at pharmacotherapy and lot of evolution, and there's a lot of wonderful molecules, but unfortunately we scared to use them because of it could be stigma or fear of practicing. So low dose, many people use low doses where you don't see a good amount of improvement. But I see that you need to really go beyond that barrier to see the real improvement. And definitely pharmacotherapy has a role, and I think we are lucky to be psychiatrists to use them appropriately. Thank you, Dr. Keshara, sir.
Yeah, very good suggestion, George. I think our time is up. I thank the main speaker, Rishikesh, for his excellent talk, and the panelists, Dr. Vishal and Dr. Ram Garu. And I also thank the organizer for giving me this opportunity. Thank you all. We are on the dot 9:30 now. Goodbye.
Keshara, thank you. Anyone?
Nothing.
Yeah.
Keshara, anyone wants to talk?
No, I don't think so. There are no more questions waiting here.
Okay. Thank you very much, Dr. Keshara. Thank you, Rishikesh. You have done an excellent presentation. I take the suggestion of Dr. Vishal. Probably we should make a small booklet from the slides that are presented by Rishikesh. We should make some charts which can be pasted in the schools, where the teachers will be able to identify the various psychological problems and bring some sort of an awareness about the psychological problems among children. We'll do about it in the next few months to come. Probably we should think about some program for the Children's Day, where we should conduct one more program like this. This will be mostly for the parents and the teachers. So if there are no further questions, I again thank Dr. Ram Subba Reddy and Dr. Vishal and Dr. Keshara, and especially today's speaker, Dr. Hrishikesh. Minhas, can you propose a vote of thanks, please?
On behalf of Indian Psychiatric Society, Telangana State Branch, Indian Association of Private Psychiatry, and Telangana State, and IMA Telangana State, I thank all of you. I thank Dr. Jagannath sir and Dr. George Reddy sir for allowing me to conduct this webinar. I would like to thank Dr. Keshava sir for chairing this session. I would also like Dr. Hrishikesh, who within a span of 1 hour, he completed most of the child psychiatric
conditions.
child psychiatric conditions.
The great energies. He's
yes,
having
sir.
great
Yes,
energies.
sir. Very great energy.
Yes, sir.
Dr. Ram Subba Reddy sir for talking about the pandemic situation, and Dr. Vishal in his typical way, he looks at the problems in like to the society, how it can be dealt with, going deep into the society. So I thank him too for throwing insight and suggesting need to be things to be done. I would also like to thank our technical team, Anil Martin, and our sponsors, Hans Pharmaceuticals. Thank you, one and all. I'd like to thank all the attendees from IMA, all the attendees from IPS TSB, attendees from IAPT, Telangana State, all the resident doctors, and other members who attended. Thank you, one and all. Thanks a lot. I think we can close the session.
I just want to remind you that tomorrow there is a talk on somatoform disorders by Dr. Minhas,
Yes,
and we will start exactly sharp by 8 p.m. Thank you so much. Good night, and we close the session.
Congratulations, Rishi.
Thank you, sir.
Congratulations.
Thank you, sir.
To all organizers.
Thank you, sir.
Congratulations.